Dr. LeFaver, would you like to tell us a little bit about yourself?
Sure, yeah, thanks for having me. So unfortunately, I wasn't able to join the earlier ones. I was in clinic today. So yeah, I'm a neurologist and movement disorder specialist. I'm here at University of Louisville in Louisville, Kentucky. I'm the director of the movement disorder clinic. So we see all kinds of movement disorders from Parkinson's, dystonia, essential tremor, Huntington's disease. And we also have started a interdisciplinary clinic for functional movement disorders. So once a month, we kind of see patients who have been diagnosed with FMD, and we do kind of an interdisciplinary evaluation with a psychologist, a physical therapist, and myself, and then make treatment recommendations. And one of the treatments we have here to offer is a inpatient treatment program here at Fraser Rehab Institute. So I've been involved with FMD treatment and research for several years, and I'm happy to answer any questions.
Wonderful. We're so excited to have you. You know, we already have a couple questions popping up, so I think we're just going to jump into what we've got here so far. The first question is from Emily, and she is asking, what should you do if you're not receiving any help from any services?
Well, so that I guess the situation would mean that someone has made a diagnosis, but I guess the person doesn't have much access to treatment services where she lives. Is that the situation? Or so that's challenging, and unfortunately we know that there's definitely a big lack of providers who really offer treatment options. And I think many people are in this situation that they might see a neurologist, and the neurologist tells them the diagnosis, but might tell, you know, you need to see a psychologist or psychiatrist. And unfortunately, it sometimes happens that then psychologists might not really be very experienced with these disorders and might even tell people, you know, I don't think the diagnosis is correct, maybe seek another opinion. So it's oftentimes it is challenging to find help. Well, what can you do? There are some resources, well, like your website, like what you're kind of doing, you know, to get at least sort of peer support and information, because that in itself can often be helpful. There is also some what is called guided self-help. So one of the resources we're using in our treatment program is actually based on a book from the UK. It's called Guided Self-Help for, well, the paper, I guess, was called Guided Self-Help for Functional Neurologic Symptoms. And it's actually a book that can be purchased on Amazon. So a lot of people have success using that, often in conjunction with a psychologist or therapist. But you know, we have kind of found it most helpful, especially for people who are more severely affected, if there's a combination of physical therapy as well as more psychological therapy services. You know, you can ask maybe if you have a physical therapist in your area who's interested, you know, you can tell them about, you know, to try to get them interested in functional movement disorders and ask them to educate themselves, because there have been a number of resources published. I know by Glenn Nielsen, who was one of the speakers earlier. So, you know, I think there really needs to be more education of providers and hopefully more services in the future.
Great.
That's my hope.
One of the questions, which is actually a very simple question, but a very important one that's hasn't been asked yet. And what is FND in kind of a layman's terms? Because as you know, there's kind of some different ideas, actually, a little bit on what different doctors think it is. So.
Sure. Well, so the term that I like to use, and I guess what you're using, is really functional neurologic disorders. You're right, there are a lot of different names that different people use and kind of talking about the same thing. I think the most kind of the oldest term, or what was sort of traditionally used, is conversion disorder. And basically that goes back to like an idea that Sigmund Freud mainly kind of propagated, and that was sort of the idea that a person has adverse experience in their life, maybe an abusive situation or some sort of a trauma that cannot be dealt with in a productive way, and then the brain kind of converts this from a physical or like an emotional trauma into a physical symptom. Now, this is really a theory and it hasn't been proven. And we oftentimes have a situation that people develop these disorders without really a proven or any more traumatic situations or stressful situations than most other people. So I don't really think it is very productive to kind of be so hung up or insistent on this whole conversion theory, since we don't have it really proven. I think there's many different pathways which can lead people to develop these disorders. So basically what it is, people can present with any neurologic symptoms. So most often is either too much or too little movement. So it can be weakness, it can be tremor, gait problems, jerky movements, all kinds of things. And the underlying commonality is that the testing we do is usually normal. So there's no brain tumor or mass or demyelinating lesion like in multiple sclerosis. So it's not really that the structure is wrong or is permanently affected, but it's more that the signals are not passed on in a correct way. So we kind of think about it as an interruption of normal signals, of normal body control. And because it's not a permanent damage, it's kind of a good thing because there are ways for people to get better.
That's wonderful. We also have our next question. And Amy, do you want to go ahead?
Oh, sorry. Yes. Could you please say how common is it for patients to have greatly fluctuating motor symptoms, which can vary from appearing normal to crawling within matters of minutes, please? And sort of if symptoms can persist for weeks or hours, but they vary so rapidly and widely, it's quite difficult to manage. So how do you request that such patients request help from physiotherapists? Because it can be quite difficult to get intervention if you don't know when you'll be symptomatic or not. And it's also quite difficult to get medical professionals in the workplace to take you seriously.
Right, so it's challenging, and that's really often the situation that symptoms vary quite a bit, even within a day or within an hour or something like that. So, I think different symptom presentations are best amenable to maybe different types of therapies. So on the one end of the spectrum are people that I often see in my practice that have the symptoms every day pretty permanently, like let's say a tremor or a gait problem. And I think to kind of work with physical therapists is probably most productive if the symptoms are present every day, and the therapist has an opportunity to kind of help kind of retrain the body and retrain these movements to kind of be more normal. On the other end of the spectrum are probably people who have what is often called PNES, or psychogenic non-epileptic seizures. So that would be a situation where during the episode, patients experience what looks like a seizure, but is not due to epileptic discharges. So very dramatic, very abnormal movements, even loss of awareness. But then in between the attacks, people actually function quite normal. So in these types of situations, it's probably a physical therapy is probably not the best treatment option, because while someone is in a spell, they're obviously not going to be able to do physical therapy. And in between, you're more or less normal. So for these types of situations, probably working with a psychologist is the better option. And there are certain therapists who have developed more specific programs for PNES. For example, Bridget knows Kurt LaFrance very well, who is at Brown University, and he has developed a 12-week program for more psychologic-based therapy, and that is now replicated at other places as well. So I think it depends a little bit on the symptoms, what kind of therapy might work best.
Thank you. Yeah, it's more that if so obviously there are non-epileptic associated attack disorder, and you can, so if symptoms come in quickly but then persist for matters of weeks, then I suppose you could argue that it wasn't necessarily just the attack. It's like a prolonged exacerbation of something, and in that period of time, physiotherapy would potentially be very valuable.
Sure. Yeah, I agree. And, it just depends what is the situation in your healthcare system, what access do you have. But I agree. I mean, oftentimes if people have really very prolonged symptoms, an acute hospitalization or treatment in a rehab center can definitely be helpful, with the caveat, but the therapists need to really understand these disorders. If they, unfortunately, I hear this over and over again, but people have the experience they are not really treated respectfully or not taken serious, as you said. And so sometimes it can be counterproductive if you're in a situation where the people, what should be your therapeutic team is not really having kind of this understanding. I think it is difficult. So I don't have a perfect solution for these situations, unfortunately. We have started our treatment program here 2.5 years ago, and we're actually starting to train other people. So we have a course coming up in October for therapists and psychologists to learn about the treatment methods. And I know that Glenn Nielsen in the UK and John Stone, that we're also organizing treatment courses. So I'm really hoping that more and more therapists are going to be more familiar with these disorders.
Thank you. You also, I just kind of want to plug in, mention the difference in treatment for what's typically for non-epileptic seizures versus movement disorder symptoms, and I think that they are under that same umbrella, but there can be some pretty significant differences for that. And there are several other treatments, as you mentioned. Kurt LeFaver has one. There's also Emory University definitely has a good program for that, and also Stanford, which Stanford will be bringing on in a couple weeks. So I think just letting people know that those others are there. That's not necessarily the focus of your program, that has more of a multidisciplinary approach, such as Stone's and Edwards's. One of the questions that we have here is, if more of them come in, they start to jump around on me. Do you do outpatient consultations at your facility, even if you know ahead of time they would not qualify for inpatient treatment?
So usually we have quite a bit of referrals. I think last year we got over 150 referrals, and we only do our clinic once a month, so we have only slots for 3 people. So we try to look at records ahead of time and try to primarily have people come where we think who might be good candidates for our inpatient program. And it's just a bit of an access as issue, and also people have to travel. If people have to travel, I don't want to take everyone's time and resources to come here and then not really being able to have much to offer. And mostly if people's symptoms are not really severe enough to justify an inpatient treatment, and so that would be kind of one reason. Or if it appears that there's kind of a very strong psychiatric issue that needs to be treated more acutely, like for example, someone has very severe depression, or for other reasons is not going to be able to participate in sort of daily 3 hours physical therapy, then that would probably be a situation where our program is not the best. But I mean, generally, if I see obviously also people here locally, I mean, we do refer some people for outpatient treatment. But again, if I see people from out of state, I'm not going to be having the opportunity to really follow people in the outpatient setting. So generally, we kind of pre-screen referrals a bit and primarily see people who we think might be good candidates for our inpatient program.
Thank you. Our next question is going to come from Maggie. Maggie, do you want to go ahead and ask?
Yeah. Is it possible to have FND on top of another disorder neurologically, because my medications, they work and then they wear off. I'm actually coming to see you in May, but I figured I asked the question because I've been going through this for a while, and that's why I was just wondering, is it possible to have FND on top of another issue that's going on, like another neurological disorder?
Sure. Yeah, that's a very good question. And I think it certainly can be the case. I mean, obviously I can't comment right now on a specific situation, but there's several situations. I mean, one situation would be, is it possible to be diagnosed with FND and actually be misdiagnosed?
Yeah, I was just wondering because I've seen a lot of on the FND Hope that some people have FND on top of something else, and that's why I was wondering, is it possible to have multiple diagnoses as well as FND?
So yeah, so it's certainly possible. I mean, one example is patients who have multiple sclerosis. So sometimes people can, we know they have multiple sclerosis. There's brain imaging abnormalities. There's other, abnormalities in lab testing consistent with that. But then people can, on top of it, develop spells which seem to be more functional. So that situation can certainly occur. If you're kind of in a situation where you were diagnosed with FND, but you're kind of, afraid something else is being missed, I think it's always the best kind of issue to be, or to the best option to really see a specialist, and either a movement specialist or seizure specialist, depending on your symptoms, and to just really get a thorough evaluation. So yes, it is possible to have things missed, but I have to say it is fairly uncommon. And John Stone and some of his group actually did a review of kind of like how often was a diagnosis of FND changed when you follow people. I think it was for 2 years. So kind of looking back, how often was an additional diagnosis added, or maybe something else surfaced, and it was less than 4%. But just fairly uncommon, and probably in the range. So I would say it's not an extremely common situation, but it certainly is possible. And, so just reviewing your history and your diagnostic tests with a specialist would be the best option.
I just have a...
Oh, sorry. There's a delay in there. Sorry, didn't mean to cut you off. We have another question from Faye. Since we're kind of talking about the comorbidity illnesses, is it possible to have non-epileptic seizures and epileptic seizures, which it is? So I'm going to go to our next question. If so, how do you distinguish between the two?
So with seizures, there's a specific situation because we do have sort of a more definitive test to tell the difference. So generally, if people have spells where there's some unclarity, are these epileptic spells or not, generally people get admitted to an epilepsy monitoring unit. So you get an EEG, kind of a brainwave reading test, and the goal would be to actually record a spell, and then the EEG reading would look very different whether or not it is an epileptic or non-epileptic spell. So that would be basically how the difference can be really defined. So that is a situation, like Bridget was saying, you can have epileptic and non-epileptic spells, although again, it's not extremely common. And maybe going back to the past question again, so we actually just looked back at, we started our multidisciplinary clinic just about a year ago. And so we looked at all the patients that were referred to us. So everyone was referred with a diagnosis of FND. And so we saw 36 patients in this last year. And we were looking back like, well, how often did we agree with the diagnosis versus disagree? And there was actually only one patient out of the 36 where we kind of recommended additional tests, because we thought, well, maybe actually there is more like a seizure-like phenomenon. And finally, we haven't actually received these test results back yet. But most of the time, we agreed with the referring physician's diagnosis.
a next question that we have is from an anonymous. Our viewer says, once symptoms are resolved and severe functional gait disorder improves, what is the chance that they will return again?
Very good question. So I think it's often a concern, that people get better and are very obviously often very ecstatic to feel better, but there's always this lingering fear of what if it comes back. And I kind of like to tell people, FND or FMD, I see mostly movement disorders, so I usually refer to it as FMD. So it's not something you just snap out of, right? This is not like, oh, you have a pneumonia, you get antibiotics, you're going to be cured, no looking back required. So oftentimes it is really more a situation where you have sort of a vulnerability to develop these kind of reactions. And oftentimes it is in reaction to certain stressors, but not always. So what we have seen with patients who did our program, we usually follow them at least for 6 months, and for local people, I see them usually back every 6 months or so. If for a 6-month time, most people who do well are able to maintain the success, which is very good. I have definitely seen people that are under periods of stress or something else happening, some of the symptoms come back, but a lot of times they tell me, I have learned now how to deal with it or how to fight back, so I've been actually very impressed with how well people can learn these things and basically get in control of their symptoms, which previously have been so much out of their control. So it's not, I think having kind of that fear is very understandable, but the goal of any treatment will be to really teach you the methods, how to kind of help yourself better and how to overcome some of these symptoms. So ideally, you'll have basically some tools in your toolbox that you can go back to and really utilize whenever you will need.
Great, thank you. Emily asks, what are the chances of recovery?
Well, so there's a lot of factors playing into that, and traditionally they have thought the longer the symptoms are present, the worse the prognosis is. So we don't have very reliable numbers from like a large number of patients. So, it really depends. Are you going to receive treatment? Is the treatment kind of successful over, what amount of time? We don't understand really, because there haven't been really a lot of head-to-head trials of different treatment options. So different treatments might work better for certain patients. So I can mostly kind of speak from my own kind of treatment experience. As I kind of mentioned, we have this inpatient treatment, which is actually only a 1-week kind of a boot camp approach. And we have seen pretty good success in about 85% of people. And then 75% were able to maintain it at 6 months, and most of them now much longer. So, it's not kind of, this is kind of just based on my own experience, and other treatments or other studies in the UK have reported similar numbers, but I think they really need to learn from more people, and I think the registry now that FND Hope is starting is a very good step in the right direction to learn more about the long-term outcomes.
Thank you. There's another question here referring to ADHD. It kind of is more of a personal medical question, so I don't want to go into the whole bit of it, but I have noticed with some discussions on the pages too that there seems to be several members that do have ADHD, and basically they're wondering have you noticed this to be common amongst people with FND, or if there's anything that may be triggering it or contributing to it. Oh. And it seems like Dr. LeFaver has gone really still, or maybe she's lost some internet connections. So as we work on trying to get her back, then we will look at some of the other questions that people have. Let's see, do patients have family histories of these disorders? That's actually a question that was asked in one of our previous, I think it was with Dr. Tim Nicholson, that he did mention that there is no evidence pointing to say that it is handed down from family to family. However, there are some genetic dispositions that are found in a lot of different illnesses, and they're not ruling out the fact that there could be just that in FND as well. Let's see. Look at some other questions. Hopefully, we did hit the 30 minutes, so maybe she won't be able to get back in. Is there any outpatient doctors in the Midwest if Dr. LeFaver doesn't see those patients? There are some doctors out in the Midwest, but Dr. LeFaver's program is the only one that we are aware of that is actually does the multidisciplinary approach and has a more structured type program. So, in that the tailors more to the movement disorders. There are other treatments that tend to focus a little bit more on the PNES. And so let's see if there's any other questions. It doesn't look like, oh, Emily asks, can you have FND for life? Unfortunately, yes, you can. FND can be chronic, and it has nothing to do with whether a patient is trying hard enough to get better or not. That's definitely a fallacy that for some reason some people run into, but you can have it for life. And if that is the case, then the doctor does need to do their best to make sure that accommodations and things are made and that you do get continual care. Doctors that deal with this in Ireland, I believe Dr. Edwards goes up to Ireland. I think I've heard that before. I'm not sure what parts though. So that would be something that we could look into further if you'd like to email us at contact@fndhope.org. We can find that out. It doesn't look like that Dr. LeFaver is going to be able to make it back in. Like I said, we kind of hit our 30 minutes. Anyway, we're trying to keep these as short as possible. So I just want to tell everybody thank you for being involved in Awareness Day. And it's really important that we all work together and stay unified. There's still a lot more that we need to do together. And go to the website, check out, we've got an amazing art auction going on, beautiful art. It's a great way to pass along the link to your friends and family, ask them to pass it along. And it's a great win-win situation for both of us. So if you could pass that along. If you're in the UK, we've got a template to contact your MP. So we ask that you consider taking the template and filling that out. We are going to be doing more of these webinars and trying to bridge that gap for those that can't reach doctors and letting you ask them questions. And so we're hoping to do another one in a couple weeks. And then we'll also have Dr. John Stone here on May 9th. And so that registration will open up in probably next week or so. So again, I just want to thank you all for everything that you've done to help support FND Hope. And we hope that we can continue to work together to empower patients to better health. So thank you.